Well, good morning. This does not sound like a crowd of agents of change, so let me get you fired up, because it's going to be a long day. So my work, if you're not familiar with it, at George Washington University has really been about moving public health beyond just empathy and treatment and recovery to fundamental change, to how do we think about strategy that gets to the true root cause of a lot of the things that we see with regard to mental health, healthy behaviors, health promotion, really getting to that root cause. And so that meant that doing that work meant that I was going to have to challenge, we were going to have to collectively challenge what we think we know and how we've been framing our work for the last 30 years. And so with that, building community resilience really had at the center of this work is a reframing of resilience in itself. That recognizing that it's not enough to help people bounce back if we can recognize that where they're starting from was not a fair start to begin with. That really when we talk about resilience in this work, what we're talking about is not only how do we put in place the treatments for recovery so that individuals can bounce back from an acute shock, but also focusing on those supports and buffers that we need to put in place to help communities bounce forward. And so that's the nature of our work. And that is what I'm here today to talk to you about, is to really truly understand how we go about moving from empathy to overall strategy. So when I first started this work, I started very tightly on looking at adverse childhood experiences. Now, how many of you in this room are familiar with that? Just give me a show of hands, because I don't want to talk past and leave anyone behind. Good. So adverse childhood experiences really was one of those issues that I saw cut across all of our public health issues. So the literature has shown that adverse childhood experiences are also associated with long-term risks with regard to mental and behavioral health, obesity, diabetes, even autoimmune diseases, particularly in women. So if we could see that these experiences that were happening early in life had a longitudinal impact across the lifespan, then isn't that a charge for public health? Instead of going down silos of obesity, diabetes, heart disease, and all these chronic diseases, what about if we thought cross-cutting and looked at adverse childhood experiences? Because not only were they cross-cutting with regard to outcomes, they were also cross-cutting with regard to who they were occurring, who was experiencing them. Because you see, the data show that adverse childhood experiences are truly an American issue. That it's happening to all of us, regardless of your race, regardless of your education or your income levels. But the differences lie in what do you have to access to bounce back. And that's where we saw the differentials with regard to outcomes. That those individuals that were living in less equitable environments had a less opportunity to bounce back. So, okay, there's a brilliant nugget of information and synthesis of the literature. But what do we do about that? You hear all the chatter about collective impact. That's great, but how do we go about doing it? How do we go about doing that from a public health perspective? So then was born the Building Community Resilience process. If you tell me we can't do it just because we don't know how, then let's go back to Public Health 101. And so the Building Community Resilience process was just that. How do we create shared understanding across multiple sectors with community partners? What is the problem that we're trying to solve for our community? What is the narrative of adversity, of trauma, of inequity in our community? Not just crunching the data, but really hearing the narrative of community. And when we understand that, then how do we go about assessing our state of readiness? What do we have that we can bring to bear to solve this problem? And when we go through that process of assessing our state of readiness, invariably we realize we need housing, we need criminal justice, we need law enforcement, we need public education, we need the business community. You see, it's going to be much more than just public health to solve this issue. And so we begin to systematically bring those cross-sector partners in, helping them to understand that shared narrative. But most importantly, throughout this process, we have community at the table. There is nothing that we do without that community voice. And let me give you one good reason why. When I first started, or example of a good reason why, when we started this work in Washington, D.C., I was working with a group of clinicians who said, we really want to go upstream. We're going to tackle the social determinants of health. We're even having it built into our EHRs. It's like, great, fantastic. What are you thinking about doing? Well, we understand from our data that we have issues with regard to diabetes, heart disease, obesity. So we were thinking, maybe we should have a clinician come in or a nutritionist come in and teach healthy eating classes. And maybe we could even have this nutritionist at the local grocery store, and they could walk up and down the aisles with our patients and help them choose healthy, make healthier choices. And we also noticed that our moms seem to be a little detached, so maybe we should have a mom support group. So, that's all reasonable if only we do is look at our systems data. But what did your patients think of this idea? Crickets. I said, wait a minute, we haven't talked to patients. We don't know where all these grand ideas fit in their priorities. So let's hit the pause button. How about I take 6 weeks, I sit in your waiting room, you allow me to talk to patients and ask one simple question. What is the greatest barrier for you to achieve maximum health and well-being? Just talk to me. So in those 6 weeks, what I heard was never entered into an EHR. The number one issue across the board, men and women, that what they felt was their number one barrier to achieving maximum health and well-being were their interactions with Metropolitan Police. This is in a predominantly African-American neighborhood in Washington, D.C., Ward 7, Ward 8, east of the Anacostia. And it was also the summer when we had major crackdowns with the Metro Police around fare jumping. So you had 12-year-olds who were being shaken down by police officers because of a Metro card. You had people that were being accosted on the buses, not by thugs, but by Metropolitan Police. So parents were afraid to let their children roam freely in the neighborhood, in addition to all of the other issues with regard to being in Ward 7 and Ward 8. The other issue that came about, every woman that I spoke to that summer spoke very candidly about her history of being a victim of sexual assault, whether that be through an intimate partner, family member, community member, what have you. Again, that was not in the EHR. But helping to take that information back to the physicians really did change their perspective on what are we going to do to go upstream. Maybe we should be partnering with Metropolitan Police, because guess what? We're the #1 provider of health care in DC jails. And that has led to a series of community conversations, which long-term, we hope, will bridge between police and community to lower those stressors, to remove some of those barriers. So then the other pieces that physicians are talking about fit into a much holistic process. And so that's really what the Building Community Resilience process looks like. And over the last 5 years, it has exploded. We started in 5 cities and 5 child health systems. And now it's embedded across 10 different regions, embedded in city government, state government. We have city hall, local health departments. We have business community members. We have community members who all recognize the value of taking those 4 simple steps, Public Health 101, and really getting to the root of the problem. And so let's talk about the root of the problem. Many of you may have seen this tree. This thing has a passport and has traveled around the world. I envy it. But it was our effort to create a very simple message, a visual, about the problem that we're trying to solve, what we call the pair of ACEs. Adverse childhood experiences in the context of adverse community environments. Now, from a public health perspective, one might look at those branches and those leaves and say, that's where we have been in public health, secondary and tertiary interventions, treatment, recovery. But primary prevention is actually in those roots. Primary prevention is looking at what are the sources of chronic adversity in our community. What is the context in which these things that are occurring as far as adverse childhood experiences? What's that context? What's that driver? So when we talk about going upstream, it becomes very clear that we're not just talking about what's happening in community. We're talking about systems drivers. We're talking about policy. Yes, big P policy. And guess what? That's the role of the chief health strategist. That's public health 3.0. And so that's why you've seen these public health departments join into this work, because they do see BCR as a process of convening, of bringing together these multiple sectors, of also examining the policies that are driving these negative, chronic outcomes in our communities. Because it's not just about public health, it's about equity. At the center of public health is social justice. If we aren't doing it, who is? And to hit the pause button here, if you say, well, I can't talk about equity, that's a third rail. I have been in Edinburgh, Pennsylvania, East Texas, rural America, talking about equity because there are a number of different ways to measure equity in this country. Yes, we go to race because so many of the inequities start there. But I would challenge you to think about the inequities comparing urban versus rural America. Inequities with regard to income, which is growing in this country. So when we started having that really authentic conversation with communities, and you're not willing to talk about equity, go home. Because you're not doing anyone any favors. Because if you're truly dedicated to creating resilience in communities, then we have to be at the center of the conversation that understands equity and understands that social determinants aren't necessarily social, and they certainly aren't determinants, but they're community, they're systems-driven community characteristics. In other words, many of these social determinants that we've used to shape programs and practices for people are performance indicators for our systems. And so how did we get that leap? Well, we hit the pause button, we left the public health literature, and we went to public policy literature to really understand the history of the policies that are driving the outcomes that we see. So many of our social and criminal policies were absolutely designed for the inequities that we see in our communities. So I'm not going to go through 400 years of history because I only have 7 minutes left. That's not what you came for. But I'll pick out one, and then we can have a little tail that goes with it. So in the middle of that policy timeline, you'll see the New Deal, and you'll see redlining. How many of you are familiar with the concept of redlining? Not enough. So let me do a quick primer, and then you can Google it. So redlining, this is when the federal government got into the mortgage business. And basically we had, as an incentive for the growing middle class post-World War II, the government started federally backing mortgages or guaranteeing mortgages with a caveat that they would only back mortgages as long as they were in white neighborhoods only. No integration, and certainly not in primarily communities of color. And so what did that do? That meant that local banks were disincentivized to actually write a mortgage to a family of color, let alone a neighborhood of color. So, using your public health data, fast forward to 2020. Many of the neighborhoods that were redlined, meaning they would not back these mortgages, the vestiges of those can still be seen today. Because these are the communities that we have where we have concentrated poverty that have been historically that way for 60 or 70 years. Take your public health data, lay on those areas where you have the concentrated poverty, concentrated adversities, chronic disease, on top of one of those redlining maps, and you'll see an almost one-to-one match. That's what we're talking about, systems and outcomes by design. And so how does that translate, say, into our public health or our public education system? Well, when we look at areas of concentrated poverty, those are the areas that have the least amount of money with regard to how we finance public education. Because public education is largely funded by what? Not the feds. There's a small amount of that comes from the feds, but most of it is local funding by district, varies by district. So what we have operating in plain sight is a two-tier system of education. And you know from the public health literature, what does that mean for children that are coming from under-resourced schools? Areas of highest concentration. In fact, the children that absolutely need the most supports and buffers are the ones that are getting the least, because that's how we fund our schools. Well, also, typically, when you have areas of higher concentration of poverty, you have lower outcomes with regard to education, you also have differential policing practices. Which means that when we talk about the school-to-prison pipeline, if you have differential policing practices both in community and within schools, then it's not an accident. It's not just about bad children. When you look at higher contact rates, when you look at higher incarceration rates, when we look at the number of children that are cycling through juvenile justice, and what their largest crime is being poor and in need of mental health care. Because in this country, our criminal justice system is the largest provider of behavioral health care. So as public health, with all of these data that we know and all these policies and systems that absolutely feed into the outcomes that we're charged with changing, then policy is in our wheelhouse. And pulling these sectors is our number one charge. So that's the resilience catalyst in public health work that we just kicked off last year with 5 public health departments across the country. Is really working as that convener in public health, reframing the social determinants of health and helping our partners, our cross-sector partners, understand that their performance indicators are really the social determinants. That we're not going to program our way out of this. We also have to be thinking about our policy and being very active in undoing policy, but also how we implement policy and how that affects public health. So I want to walk you through a little bit here about these systems-driven community characteristics. So if you look at the yellow box there, many of you are familiar with these as what we've ascribed as these social determinants. And we've used these to think about what do we need to, how do we change program? How do we change practice so that we can have increased graduation rates, so that we can have fewer children that are cycling into juvenile justice? But I challenge you to bring your systems partners to the table, because these are actually their performance indicators. These are actually how we measure within systems how well they're operating. They're making their funding pleas, and they're writing their packages for funding and justifications for their programs based on these indicators. So why at public health are we then turning the lens back on our community and not necessarily back to the systems of which are in charge of these outcomes? But that's part of the collaboration piece of this. So what we've done is use these indicators that are in the yellow boxes to start using systems dynamic modeling. Policy as the intervention, because this isn't squishy. Equity isn't squishy and neither is resilience. We can measure both. And that's what we're doing in this work, is using these indicators to begin to understand across all of our sectors, what are we doing in this all-in strategy to improve our outcomes at the long term for public health. And so as you'll see there, this is what is truly reframing the social determinants. Looking at going way upstream to those systems. Housing, public schools, criminal justice is where we start. And why is that? Because we know from our public health literature that these are the systems that have the most impact in influencing our community environments, influencing the resources that are available to our community members, influencing those long-term health outcomes. So I'm challenging you as an agent of change to reframe your thinking around social determinants, moving from just empathy to strategy. And you're not alone. As I showed you on that map earlier, we have partners across the country. We have federal partners that have invested in this work, as well as local city governments that are vested or rolling up their sleeves. And when it comes to the equity conversation, there can be no more important conversation to have than that. Because if you're not willing to not just take in the information and hear the narrative of equity or inequity within our communities, but then not willing to do something about it, you're not truly serving your community, not in an authentic way. And equity can be measured in a multiple range of measures. Yes, it's race, but it's also urban versus rural. It's also rich versus poor. It's also thinking about education. There's thinking about criminal justice involvement. There are a lot of ways to measure equity. Meet your community where they are. That's how we've been successful. That's how we've been able to do this work in areas such as East Texas and Washington, D.C. Because we meet our community where they are by listening to their stories, understanding what does upstream look like for them, and what are the downstream impacts, and how do we create these measurements that truly affect change. So that is the work. That is resilience. I hope you understand it now. But I also hope that this helps to charge you to really truly understand that it's not just about treating and recovery, that true prevention means that we are getting in the roots and we are working with our systems partners, not blaming, not shaming, because no one that's here today has really written that 400 years of policy. We're all stuck in the same machine. But as agents of change, we can break that machine. And we can build something that actually helps to improve health and well-being, and that's what true resilience, community resilience, looks like. So I know many of you are doers. We're all doers. And I want to help you in the work that you're doing by going to our website. All of our tools and resources are free because that's equity, not contributing to the gap. In fact, all of the tools that we've created webinars, so you can go and you can download, you can listen, not just to us, the national team, but the other communities that are implementing this. And our latest tool is going to be released at the end of the month to help guide others in the equity conversation, to help you meet your community where you are, so that we collectively are agents of change and will build a resilient nation. Thank you.